Good evening, everyone. This is our 21st online teaching class under the banner of UB chapter URI. And this is the fourth class under the heading of the breast session. So for this, I would like to invite Dr. Radha Kesarwani. She is the Professor, Department of Radiation Oncology, Motilal Nehru Medical College, Allahabad. Dr. Radha, it is over to you.
Thank you, Dr. Surbhi. As we are continuing our 21st online classes under the aegis of Association of Radiation Oncologists of UP chapter, in continuation of the management of the cancer of the breast, today's topic is hormonal therapy in carcinoma of the breast, for which I would like to invite Dr. Sushma Agrawal, ma'am. Ma'am is professor in Department of Radiotherapy in Sanjay Gandhi Postgraduate Institute, Lucknow. Ma'am is graduate from Mahatma Gandhi Institute of Medical Sciences, Wardha, and postgraduate from Institute of Medical Sciences, Banaras Hindu University, Varanasi. Ma'am has won many awards and published many papers in national and international journals. Now I am handing over to ma'am. So Dr. Sushma Agrawal.
Thank you, Radha, for the introduction. So without wasting any time, I would start with this lecture. So I have been given the topic of endocrine therapy in breast cancer. And so the roadmap would be, first of all, I would discuss the role of adjuvant endocrine therapy in early breast cancer, then in locally advanced, and lastly in metastatic disease. So what is early breast cancer? It is stage 1 and 2. And in advanced, stage 3 is locally advanced and stage 4 is metastatic. Now, before moving on to the role, we have to know the biology of the breast cancer. And we are all familiar that it is divided into basically broadly 4 types. One is luminal A, which is predominantly ER-PR positive. It is low grade. The second is luminal B, which is also ER-PR positive, and it may have HER2 positive or negative, but it is higher grade than luminal A. The third is HER2 enriched and ER-PR negative, and the fourth is triple negative. If you see lower down, the proliferation rate is highest in triple negative, which leads to its poorest prognosis, and the highest grade tumors fall in triple negative, again leading to the poor prognosis. And if you look at the ER-PR positivity, it is highest in luminal A's, and they are the lowest grade. And also you can appreciate that the luminal A's comprise of 60 to 70% of the breast cancers in the West. Not so in India. In India, it is about 30 to 40%. We have a higher percentage of triple negative. But nevertheless, 40 to 50% is a great percentage. So we have to understand the biology and the role of endocrine therapy well. After knowing the biology, let's start with early breast cancer. And the early breast cancers are T1s and T2s. So the T1 can usually be given their breast can be conserved. But in T2s, they may have to undergo upfront systemic chemotherapy to make it smaller and then undergo breast conservation if possible. And if in spite of this, if breast conservation is not possible, then these women undergo mastectomy. So this is the local therapy, and then this is followed by post-operative radiotherapy depending upon the indication. And then the patients are administered endocrine therapy with or without chemotherapy. Now, with or without chemotherapy, we have to know it well in which patients to give chemotherapy. So if you look at the left part of this slide, you can see that both luminal A's and B's, as I explained, are ER-PR positive. So which are those women which are at high risk of recurrence, so that we can give them chemotherapy also along with endocrine therapy. While in those women who are at low risk, they merit only endocrine therapy. And since I am talking only about endocrine therapy, I shall not talk about the adjuvant therapy in HER2 positive and triple negative disease. So what are the factors which decides our risk group in early stage ER/PR positive patients? So if you look at this left slide, the blue lines are the ones of women having both ER positive and PR positive. They have the highest DFS. This is followed by women with PR positive but ER negative. The third are ER positive, PR negative. Why is it so important to segregate? As you can see that PR positivity confers a good prognosis. So therefore, it is important to segregate all the four. So third important part is that those women who are having very low ER/PR positivity, for example, 1 to 5%, in these women are at high risk of recurrence, and you should treat them as triple negatives and administer chemotherapy. The similar trend is there in the overall survival curve. So what did we understand from this slide is that apart from ER positive, PR positive is also very important. Its positivity confers a good prognosis. The second important part is the age and menopausal status. So if you look at this slide on the left, which is of younger women less than 50, and there are two lines, the red line and the blue line. The red line is that of women who received chemotherapy plus endocrine therapy as compared to no chemotherapy. The survival benefit at 5 years, while in the right side, which is of women more than 50 years, the similar thing was not seen. So therefore, chemotherapy is not to be given in women who are more than 50 years. Now the third thing is menopausal status, which is also a surrogate of the age. And the similar thing is seen in postmenopausal women. There is no benefit of adding chemotherapy. This is the left part of the slide. And in the right side, the same 5-year difference in DFS was seen if you give chemotherapy. And the recurrence may be in terms of locoregional, contralateral breast, or non-breast primary. So premenopausal women are the other risk factor who deserve chemotherapy. Now the third thing is that people started looking at the genomic assays. And so there are many genomic assays, and I shall discuss only one of them, which is the left one, which is based on 21 gene recurrence score. And it is done on the formalin fixed tissue by RT-PCR. And they divide the women who are of early stage into 3 risk groups. As you can see on the right side, less than 11 RS score is the low risk group, and these women should be given only endocrine therapy. 12 to 25 is intermediate risk group. This is an area of concern. More than 25, there is no doubt that these women should be given chemotherapy. But do we have this assay in our country? And even if it is there, it is very costly. The other thing I forgot to mention is that after the proposal of this risk group, this was validated in the retrospective analysis of NSABP study, and they found that this scoring system was working. But a prospective validation is important. So there are 2 trials in which the intermediate risk group patients were randomized to either endocrine therapy alone or to a combination of endocrine therapy and chemotherapy. Now, this first study which I'm showing is TAILOR-X, which was of recurrence score intermediate in node negative patients. The one which was done in node positive is called the responder trial. So what do we see here is that the uppermost curve, that is the arm A, that is the low risk group, they have only 3% risk of distant meds, while the intermediate risk group, both the kind of patients, the ones which were randomized to endocrine therapy or the ones which were given chemo and endocrine, both had only 5% distant recurrence. And mind you, this is the intermediate risk group. So what do we conclude from this? That node negative women with intermediate risk group merit only endocrine therapy. And the last line is that of high risk group, that we anyway know that usme chemotherapy needs to be given. Now now in the subgroup analysis, this showed that chemotherapy benefits in younger women, but then subgroup analysis is usually criticized. And now let's see what happens in the node positive. In the node positive patients, those women who got chemoendocrine, they fared better, and the disease-free survival differed by 4%, 5%. So, but we anyway know that node positive are high risk in our country at least. So we don't need a RS grouping oncotype DX, but then validation of this was important. So women who are node positive, early breast cancer, intermediate risk group should be given a combination of chemo and endocrine. Now we have talked about the cost of this assay. So are there any other parameters with which we can know the risk grouping? So, because cost is an important even in countries like United States, and so therefore they are the ones who did correlation of Ki67, which is a proliferation marker, and PR status positivity. Now on the right side there are two graphs. The upper one is women with PR less than 20%. So as I told you earlier, low PR is poor, more PR is better. So in low PR patients, the blue lines are that of high recurrence score. So in low PR, you can see that women who had more than 40% Ki67, they are usually high risk group. While in a high PR status, not as many high risk groups fall in this category. So since this is a bit complicated, the summary of this is that 95% of the low risk group women had low Ki67 and high PR. So if a woman comes with to us with a high PR, low Ki67 and early tumor, we know that these women can be best dealt with endocrine therapy alone. The other thing which we understand from this work is that any woman, low grade or early stage, if the Ki67 is more than 40%, you have to add chemotherapy. The third thing is grade 2 tumors are likely to be intermediate risk group, grade 3 are high risk group. So in a country like ours, we can select those patients for endocrine and chemotherapy based on the risk factors which I have mentioned. Now, so therefore the ESMO guidelines also say that genomic tests are not recommended for women with low clinicopathologic features, that is T1s, low grade, high ER and N0s. Women who have comorbid conditions, even if they have small tumors, if you can't give them chemotherapy, why subject them to genomic assays? And there are some subtypes which are papillary or tubular types which are very low grade, so you needn't do genomic assays. And women with 1 to 3 involved nodes with coexisting other high risk factors or positive nodes, in these women, you should, as it is, go ahead with chemotherapy without doing a genomic assay. So you can save the cost in these women. Now, after having known in which women I have to give only endocrine therapy, we have to know which are the strategies for endocrine therapy. The strategies are tamoxifen, aromatase inhibitors, ovarian suppression, and nowadays CDK inhibitors. So how do they work? So, tamoxifen was discovered in 1967. It took 15 years for its approval in ER-positive tumors. Its results were published in 2005 by the Early Breast Cancer Trialist Group, and they found that 5 years of tamoxifen gives 31% reduction in the risk of recurrence. And in 2011, they saw that the risk reduction was seen even up to 10 years. Means if you give 5 years, the benefit is carried up to 10 years. And this is a phenomena which is not seen in all the drugs. So how does it work? In short, if you see here, pink is estrogen, which binds to its receptor, and then it causes cell proliferation. Tamoxifen prevents the binding of estrogen to its receptor, and the cell proliferation is therefore stopped. Now, the other class of drugs, how do they work? Aromatase inhibitors. As you can see, testosterone is converted to estrogen with the help of aromatase. So if you block this enzyme, the estrogen formation will be blocked. There are two types of aromatase inhibitors. One is irreversible steroidal, which is exemestane, and the second is reversible, anastrozole and letrozole. And they are also non-steroidal. Now the third is fulvestrant. It also acts on the estradiol pathway, while the other drugs which I told you, that is the CDK inhibitors, they do not act on the estradiol pathway. So you can see that palbociclib, ribociclib, abemaciclib, they act on cyclin D1, that is the cell cycle, and that is how they have a cytotoxic effect. The other two drugs mentioned here, they act on, they are given in second line, and they act on the pathways, cell cycle, the other pathway, that is mTOR, PIK3K, and so that I shall mention later on. And after the use of tamoxifen, there were a lot of, the use of AIs, there were a lot of sequences which were being tried. We didn't know whether to give only AIs or to give a tamoxifen followed by AIs, or to give only tamoxifen for 10 years, or to give 5 years tamoxifen and 5 years AIs. But in the end, they found that all these strategies are good enough. No one is having more benefit than the other. Now, a little bit of results are important. The early breast cancer trialist group showed that the use of tamoxifen decreased the recurrence rate as compared to the control by 12% in ER positive, PR positive patients. And as the ER positivity diminished in the lower down graphs, ER poor disease, the benefit with tamoxifen diminished. So what we can understand from this slide is that the benefit is to the tune of 12% in decreasing the risk of recurrence with the use of tamoxifen in ER positive patients. Now next is the effect of age on the efficacy of tamoxifen. So if you see the younger women, that is premenopausal, less than 50 years, and here you can see that with tamoxifen, if the recurrence rate was 21%, it further decreased to 14% with addition of chemotherapy, while the same benefit is not there in older women. Here the addition of chemotherapy decreases the recurrence rate further only by 4%. So why to add the morbidity of chemotherapy in postmenopausal women? So what do we understand from this slide? That tamoxifen works more in premenopausal, and the benefit of addition of chemotherapy is also more in premenopausal women. Now, coming to the benefit of aromatase inhibitors versus tamoxifen in early breast cancer. So, when these drugs were studied, in the left hand of the slide, you can see that if tamoxifen reduces the recurrence rate by 22%, the addition, AIs further reduces the recurrence rate by 2 to 3%. And even it reflects in the breast cancer mortality by 2%. So therefore, this established the superiority of the AIs over tamoxifen in postmenopausal women. So with these, we understand that tamoxifen is administered in premenopausal and aromatase inhibitors in postmenopausal. Now the sequencing. There were a lot of studies regarding the sequencing, and a few were at year 0, whether they gave tamoxifen in one arm or anastrozole on the other arm. The difference in survival was 3%. Big 98 showed that the difference in survival was 2.5% at 5 years with letrozole. If you add AIs after 3 years of tamoxifen, then the benefit is about 4.7%. And if you add tamoxifen after 5 years of if you add AIs after 5 years of tamoxifen, the benefit is maximum. So this is in postmenopausal women. Now I will deal with the sequencing more in the later slides. Basically, this is just to tell you that there are so many types of sequential therapies which are given, and all of them are okay. Now, after having dealt with the two methods, the third is ovarian suppression. And this strategy is only to be used for premenopausal women and in ER-positive tumors. Now, there are two methods of ovarian suppression. One is GnRH analogs, and the other is oophorectomy. So it took many years for a pure GnRH analog study to be undertaken, and there were two studies. And this is a publication where they combined the results of both. So in one arm, women had ovarian suppression with GnRH analogs with exemestane, 2,000 women. And the other arm was ovarian suppression with tamoxifen. So what do you see that in terms of recurrence, the addition of exemestane to ovarian suppression was superior, even in terms of invasive disease-free survival, that is superior, but not in terms of overall survival. So therefore, its use is not so popular, and it should be given only in high-risk women. So this is high-risk women only should receive ovarian suppression in addition to adjuvant endocrine therapy, and not in all women left and right. Now coming to the other thing is that you must have observed that people were giving 5 years of AIs after 5 years of tamoxifen. So what is the genesis of that? So Pan et al. Noticed and published that based on nodal status, if you gave 5 years of tamoxifen, look at this yellow line. At 5 years of tamoxifen, the risk of recurrence was 6%. It increased to 11% at 10 years. And at 15 years, it increased to 16%. At 20 years, it became 22%. And this is in N0 patients. Now, N1s, obviously, the rate is going to be much more. It went up from 10 to 25% at 15 years. And in N2s, it went up from 22 to 50%. So you can understand the amount of recurrences rate happening in luminal A patients Though we say that they are low grade, they have the best prognosis, but the recurrence is there, which is really very sad for the patients. So therefore, this gave an insight that instead of 5 years, we should give at least 10 years of um, endocrine therapy. The other thing which he published was that if it was a T1 tumor, N0s had 31% of recurrence, N1s had 20% of recurrence, and N2s have 34% of recurrence. And this increased in T2s from 20% to 40%. So the magnitude of recurrences are really high. And so therefore, because of this, the studies were launched to test longer duration endocrine therapy. So this study is ATLAS study, which tested continuation of tamoxifen to 10 years in the blue line and stopping tamoxifen at 5 years. So what was the difference in the results? At 10 years, you see that the difference was only 1.5% in terms of recurrence. But there was a carryover effect which resulted in 4% difference. And this reflects also in the breast cancer mortality of 3% at the end of 15 years. So though it is beneficial, but it comes at a cost. The relative risk of pulmonary embolism was 1.8, stroke was 1, ischemic heart disease was 0.75, and endometrial cancer was 1.74. So we all know that these women on long-term tamoxifen have to undergo a vaginal ultrasound, and we have to be on the lookout for any evidence of thromboembolic phenomena. Now, what about extended AIs? So extended AIs are only in the form of 5 years of letrozole after 5 years of tamoxifen. Here also, and this study is called the MA17 study. And here also they found a benefit. As you can see in the upper graph, the lower one is only tamoxifen, the other one is AIs after tamoxifen. So if you look at this box here, the benefit was only in terms of DFS. The hazard ratio was 0.58, and the overall survival benefit was only in node positive patients. So extended endocrine therapy is not to be given left and right in all the patients, only in women with high risk, that is node positive patients. Now, so this is the synopsis of extended adjuvant aromatase inhibitors are to be given in node positive, large tumors, that is 5 centimeter tumors. And also we have to see whether the patient is tolerating endocrine therapy or not. Because there are a lot of reports that in the first year about only 15%, there are 15% dropouts. And okay, in this slide, you can see that in the first year, 15% patients drop out. And by 5 years, about half of them drop out because they are not able to tolerate the postmenopausal symptoms. Now, apart from tamoxifen side effects, which I already mentioned, that is thromboembolic phenomena, endometrial cancer, depression, and hot flashes, the side effects of AIs are the decrease in the bone mineral density, the fracture risk, musculoskeletal symptoms, and higher risk of valvular disease. So we have to do a bone mineral density every year. Now, the last is the role of CDK inhibitors in early tumors. Is there a role? First of all, the mechanism of action. I told you earlier that they block the CDK4/6 inhibitors, which acts on G1 phase. So there is a cell cycle arrest. Now, there have been 4 studies in early stage tumors using all the 3 drugs. And what do we see are that if you see the role of abemaciclib and palbociclib, they were not given left and right. They were only given in high-risk women, that is N1s and grade 3s or T3s or N2s, and they were given for 2 years. What was the difference in the invasive disease-free survival? Of 3%. And the discontinuation rate was 1/3 of the women they couldn't tolerate because the side effects are there, which I shall discuss later on. But it is only the abemaciclib which showed a difference in overall survival, and it has been published this year. This is called the Monarch E trial. Now, the disease-free survival was difference at 24 months. The difference was to the tune of only 2 to 3%, which I showed you earlier. And overall survival, I cannot find it here. This has been approved for use in high-risk early breast cancer. But obviously, in our country, it is very difficult to give this drug. But we should know that it has been approved, and only in patients who can be who are economically well off, they should be advised. And which are the in the forest plot, they showed that premenopausal women who obviously are at high risk, they benefit more. Younger women less than 65 have more benefit, and higher grade tumors have more benefit. So again, high risk women benefit with the addition of CDK inhibitors with endocrine therapy. I'm skipping this slide because this is only for namesake, the role of adjuvant bisphosphonates, and we are hardly using it as endocrine therapy. So to conclude, in early breast cancer, endocrine therapy has to be given at least 5 years. Only in the high-risk group, which I have already discussed in detail, they need to be added chemotherapy, and 5 more years extended adjuvant endocrine therapy also needs to be given in high-risk women. And here 4 lymph nodes or high-risk women can be given abemaciclib. I have not talked about BRCA mutated women because that is itself a big topic and the time is not there for this. But you should know that BRCA mutation is common in luminal A patients, about 30% of them have, and so its role is there in these women. Now coming to the next part, neoadjuvant in locally advanced. When it was, the studies were published, there was a big hype, but now they know that it is the AIs which give a little bit of downstaging. It is not the standard of care. It should be only given in women who can't take neoadjuvant systemic chemotherapy, in the old women who have a less longevity, and it should be given only up to 6 months. And you should never expect a pathological CR with a neoadjuvant endocrine therapy. So there is only, I have not devoted much of time for the neoadjuvant endocrine therapy. Now coming to metastatic breast cancer, this is itself a huge topic. So this is just an overview of the metastatic breast cancer, all the 3 types of biological subtypes. As you can see, in the HER2 positive anti-HER2 therapy is given. In triple negative, it is only chemo. Nowadays, immuno has come up. In luminal A's and B, apart from endocrine and biological agents, PARP inhibitors are also there. And of course, in skeletal mets patients, bone modifying agents should be given. Sorry. Now, the milestones are very important because when we were doing MDs, we had only these armamentarium, tamoxifen and AIs. And gradually in 2010, they started using a combination of 2 AIs. or in the second line setting, everolimus with exemestane. And now after the publication of CDK inhibitors, they have gained main stage, and now we shall see how. So before launching into the studies of endocrine therapy in MBCs, we have to understand the phenomena of primary endocrine resistance, secondary endocrine resistance. So primary endocrine resistance means the patient is innately having a resistance to endocrine therapy. So when a patient is on adjuvant tamoxifen or AIs, she relapses within the first 2 years, or if a patient is MBC, she relapses within the first line of chemotherapy within 6 months. What is secondary endocrine resistance? The patient who is of early breast cancer relapses after completion of 2 years of adjuvant endocrine therapy, or if the patient is a MBC, she relapses after 6 months of starting endocrine therapy. So basically, this tells us that the patient is resistant. She may not have a good outcome with endocrine therapy. Now, the other thing which you will come across is visceral crisis. So what is visceral crisis? In a woman who has visceral metastasis, for example, if she has liver mets, mere presence of liver mets is not liver crisis. It is only the presence of increasing bilirubin or biliary tract obstruction. In a patient with lung mets, it is only the development of rapidly increasing dyspnea, and these women are in visceral crisis. So why was it important to create this category? Because only in this category, they recommend chemotherapy. So with this, the other thing which is important is definition of menopause. We often see that premenopausal, we have started endocrine therapy, the woman doesn't achieve her menses. So we have to know the clear-cut definition. So clear-cut definition is obviously a woman who has undergone a bilateral oophorectomy, or in a woman who has cessation of menses after 60 years. If less than 60 years of age, then after 12 months of taking some kind of therapy, whether it be endocrine therapy or chemotherapy, but you have to confirm it with the estrogen levels and LH levels. And so this is it. So we have to be very clear that a woman has achieved menopause before starting her on aromatase inhibitors. So with that, now let's see how we have to manage the metastatic ER positive women. So with the establishment of targeted therapy, a combination of ET with targeted therapy is the first line. Whether we can give it or not is a second question. Why? Because we are belonging to a developing country, and we see that only 10% of the patients can afford a CDK4/6 inhibitor. So that is a different matter. We are in an academic session, so we have to know the science based on the evidence. And if these women progress, and if they are not in organ failure, then they should be given a combination of everolimus with exemestane if the patient does not have PIK3K mutations. If the patient has PIK3K mutations, they should be given fulvestrant with alpelisib. And if the BRCA is positive, then PARP inhibitor. And it is only in women with visceral crisis that they advocate chemotherapy. Why are they so hell-bent upon separating a criteria for chemotherapy? Is because they found that the benefit with chemotherapy was not more than with a combination of ET and CDK4/6 inhibitors. So now let's see, now that CDK4/6 inhibitors have taken center stage, does it work in ET sensitive and ET resistant subtypes? Yes. All the three drugs work in both the endocrine sensitive as well as endocrine resistant group of patients. But the only difference is that in endocrine sensitive, you give a combination of CDK inhibitor with AI, that is letrozole. And in an endocrine resistant patient, you have to give fulvestrant rather than AIs along with CDK inhibitors. So this is one main thing. The other thing is that all the studies showed good prolongation of the PFS, and OS benefit was seen only with ribociclib. So I shall only discuss the Mona Lisa study. So Mona Lisa study was in postmenopausal hormone receptor positive women, where patients were randomized to ribociclib plus letrozole versus letrozole alone, and PFS was the primary endpoint. So the overall survival benefit at 4 years was 6%. It increased to 8% at 5 years and further to 12% at 6 years. So, therefore, it has become the standard of care in postmenopausal women with metastatic disease. Now, we already know that it works both in endocrine resistant as well as sensitive tumors. What about women who have been treated with chemotherapy earlier? So, this forest plot shows us that even in women who have been treated with chemotherapy earlier, the ribociclib works. So, so now we know that it works in almost all kinds of patients. Now, next thing is that, okay, it works, but we have to know the side effects. So the side effects are neutropenia in about 75% of the patients with palbociclib, in 60% of the patients on ribociclib, and in 25% of the patients with abemaciclib. But abemaciclib has another side effect, that is 10% of the women have diarrhea. Now, once the patient progresses on first-line combination of endocrine therapy and CDK inhibitors, what to do next? So the next depends upon what kind of agents you have used, what is the duration of response to previous endocrine therapy, what is the disease burden, what does the patient prefer, can he afford the further costly drugs, and what kind of drugs are available in our setup. But before that, you have to test these women for the presence of mutations. So we are talking about ideal scenario. If we had the best setup, then we would test them for PIK3 mutations, BRCA mutations, and ESR mutations. Why? Because about 30% of the women, you can see in this slide, the prevalence of ER mutations is there in 40% of the women, and the prevalence of BRCA we know is very less, that is 4%, but PIK3 mutations are there in 40%. So if you have women who are PIK3 positive, then you can directly act on those mutations. Now, what is the evidence for the benefit of PIK3 mutant tumors? This was the SOLAR studies where they randomized the women with PIK3 mutations to alpelisib with fulvestrant versus fulvestrant alone. So they got benefit in terms of PFS, that was 6% versus 6 months versus 11 months. So the benefit was of about 6 months, which is quite huge. You are merely giving the patient 1 more year of life. So if the patient can afford, I just looked up the price, it is about 20,000 per month of therapy. But this also has side effects. So after the publication of this study, it was FDA approved both in the United States as well as in Europe for use in women with PIK3 inhibitors. And if the woman does not have a PIK3 mutation, then you give them everolimus with exemestane. Now again, what was the benefit in these women? The median PFS benefit was to the tune of about 4 months, 3 months with only exemestane and 7 months with combination of everolimus plus exemestane. But there are again side effects, mucositis in 50%, fatigue in 40%, rash in 40%, anemia, diarrhea, hyperglycemia, hypertriglyceridemia, and pneumonitis. So only you can give it in fit patients. Now, if a patient progresses even further, what do you do? So in women who have become endocrine resistant, you give them chemotherapy. But in women who are still endocrine sensitive, you do not stop the endocrine therapy. Means if you have been given AIs, you keep continuing that, and then you have to add some other agent. Now, the other agents which are there are based on the theory that, for example, if the patient was getting aromatase inhibitors, the study showed that if you remove the aromatase inhibitors and added fulvestrant, this study was based on the palbociclib study. They found that those women who progressed, and if you removed the aromatase inhibitor and changed it to fulvestrant, the patient started responding. So therefore, they did a study where women of AI plus palbociclib, if they started progressing, they randomized them to fulvestrant and palbociclib, or they continued with the same. So what did they observe was they found that there was a further benefit of about 6 months. So 6 months with the standard which they were giving, and it became 12 months PFS if you changed it to fulvestrant. So this is one important thing, and they said that it was because of the development of ESR1 mutation. Now this is the last, and that is there is another AKT inhibitors which are being studied, and it is called as capivasertib, and it has also shown a PFS benefit of 5 months versus 10 months, that is 5 months benefit, and it has also shown a 6 months overall survival benefit. So that is why it's important to mention this drug for this talk today. And with this, I would like to conclude that in MBCs who are ER positive, we have seen that CDK inhibitors along with AIs are the first line. It works in both endocrine sensitive and resistant tumors, and subsequent lines are to be decided based upon the disease burden, the aggressiveness, the molecular profile, the target expression, and the patient status, preference, and expectations. So this is the last slide, by which I just want to tell that it is only in the initial phase in this disease, which is a chronic disease. It does not manifest a death so soon. It is not like triple negative. So since it is a chronic disease and we want the best survival for the patient, so we should act with the best drugs in the initial phase. That means if the patient can afford CDK inhibitors, we should offer them that option in the initial part. Usually what we are doing is if the patient progresses, then we offer them CDK inhibitors. Because if we do that, then the patient is already downhill, and it is coming to a stage where only palliative therapy would be needed. So with this, I end my talk today, and thanks a lot for patient listening. It's time for dinner now, and if there are any questions, well, let me see the chat box. So Surabhi, I have already explained primary and secondary endocrine resistant. Do you want me to explain again?
No, ma'am. No. I got the answer. Now I just want to know what is the role of radiation castration in current scenario?
Radiation?
Ovarian castration. Radiation ovarian
Oh
castration.
yeah, ovarian castration was earlier when we were doing MD. Now it is not the standard of care. Why? Because after doing radiation castration, there is not 100% menopause. So therefore, it is not the standard. But if the patient doesn't want to go in for surgery, can't afford GnRH, then obviously we should do that.
Thank you, Dr. Sushma ma'am, for such a elaborative lecture and enlightening us about the management of hormonal management in carcinoma of breast. Ma'am, I have one question. If any patient has T2 and 0 tumor, like tumor size is 4 centimeter and hormonal positive and ER/PR negative, and her recurrence score is oncotype DX with recurrence score less than 11.
Can you repeat it? I missed in between. T2, 4 centimeter.
T2 and 0, 4 centimeter, hormone receptor positive, ER/PR negative, and recurrence score is less than 11. Then whether we should give only hormonal therapy, premenopausal, or also add the chemotherapy.
So then we have to also see the grade, the proliferation index, that is the key 67. And we have to see the percentage of ER/PR positivity. If the patient is PR positive more than 20%, it is a good risk group. If the patient has ER positivity more than 40-50%, it is a good group. Then grade is also important. If the patient has grade 3 tumor, you add chemo. Premenopausal, you add chemo.
Premenopausal, okay.
Yeah. But if you have the genomic typing, then you go by the genomic. You said recurrence score
less than 11.
Less than 11. उसमें only endocrine therapy. मैंने ये जो बताए थे, ये इसलिए बताए थे कि अगर हमारे पास, हम तो जीनोमिक टेस्टिंग करते ही नहीं है.
हाँ, एक्चुअली 4 सेंटीमीटर में यूजुअली हम लोग तो कीमोथेरेपी देते ही है.
हाँ, 4 सेंटीमीटर. हाँ, तो वही है, लार्ज ट्यूमर्स, नोड पॉजिटिव,
नहीं नोड नेगेटिव, T2 and 0. ओके.
तो T2 में तो देते ही है, कीमोथेरेपी तो देते ही है. बट अगर जीनोमिक टाइपिंग है आपके पास, देन दैट इज द सुप्रीम थिंग. देन यू डोंट हैव टू गिव कीमोथेरेपी. बट अगर आपके पास जीनोमिक टाइपिंग नहीं है, देन यू हैव टू अप्लाई योर माइंड.
And there is one question in the chat box. Is there any benefit of ovarian ablation triple negative tumors?
No, ovarian ablation is only to be done in ER positive tumors, not in triple negative or in HER2 negative disease. Oh, sorry, HER2 positive disease.
I think there is no more question left. So thank you so much, ma'am. You elaborated so nicely. I think the student must have cleared their doubts. So there is a very last question. Thank you so much once again, ma'am.
Thank you, Surabhi. Bye. Good night.
Okay, ma'am. Thank you, Dr. Radha. Thank you so much. Thank you all the participants. And
thanks, Radha.